Good evening, and welcome to Keeping an Eye on Multiple Sclerosis. This webinar and telelearning series is brought to you by Can Do Multiple Sclerosis, the National Multiple Sclerosis Society, and the Multiple Sclerosis Society of Canada. My name is Laura Coyne, and I'm the Programs Manager for Can Do MS. I will be your moderator this evening. Can Do MS transforms lives. We deliver educational programs on exercise, nutrition, and symptom management to inspire and motivate long-lasting change for those with MS and their families to help them thrive. Please visit Can Do MS's website, mscando.org, to learn more about Can Do MS's online and nationwide in-person programs. Can Do MS is excited to partner with the National MS Society to bring you 15 webinars in 2017. The mission of the National MS Society is to help people affected by MS live their best lives as they stop MS in its tracks, restore what has been lost, and end MS forever. You can explore other society programs, services, resources, and connection opportunities at nationalmssociety.org. Our speakers this evening are Dr. Tarek Bhatti and Dr. Diane Whitaker. Dr. Bhatti is a neuro-ophthalmologist. He is affiliated with the Departments of Ophthalmology, Neurology, and Neurosurgery at the Duke Eye Center and Duke University Medical Center. Dr. Diane Whitaker is an optometrist and low vision rehabilitation specialist. She is the Division Chief of Vision Rehabilitation and Optimization at the Duke Eye Center and an Assistant Professor of Ophthalmology at the Duke School of Medicine. I will now turn the program over to Dr. Bhatti.
Laura, thank you very much. First, I want to take this opportunity to thank the Can Do MS, National MS Society, and the MS Society of Canada for asking me to give this talk tonight. It's certainly a great privilege, and I hope that all of you who are listening will not only be enlightened by what we'll talk about, but as well as entertained. So the title of my talk this evening is Keeping an Eye on MS, and what we're going to do is really concentrate on how multiple sclerosis can affect the eye, and what one can do when it does happen, and what one may experience. In terms of vision problems and multiple sclerosis, it's actually pretty common. Many patients living with MS have vision problems, but the good news is that rarely does it result in total blindness. So patients may have impaired vision. Often it's transient or temporary, not permanent. But even those who have permanent vision problems often are not completely blind. They may certainly be disabled by their visual problems, but are able to meet those challenges, as we'll talk about in a little bit. Also, it's not just those patients living with MS who have vision problems. In fact, vision problems may be the first symptom or sign of multiple sclerosis. And so this talk sort of parallels a talk that I often give to healthcare providers, other ophthalmologists, neurologists, internists, etc., because very often patients may have vision problems as their first manifestation of multiple sclerosis, and they will never have known that they had MS until these vision problems occurred. There are several things that can occur in terms of vision in people living with MS. As you can see at the bottom of this slide, the potential problems include optic neuritis, which we'll delve into a little bit more specific in the next few slides. Also, sometimes patients, after they improve from their optic neuritis, will have temporary blurred vision, especially if their body temperature goes up, and that's called Pulfrich Phenomenon. We'll talk about that. Other vision problems that people will have is uncontrolled eye movements, or what we call nystagmus, dancing eyes. And then finally, there's some people who can have double vision, where they actually see two images of something that can occur either when they're looking straight ahead or looking to the sides. So let's just briefly talk about multiple sclerosis in terms of the anatomy, and then by doing that, hopefully people will be able to understand why is it that the eye and vision is so often involved in multiple sclerosis. So I think most of us are pretty familiar with the central nervous system, especially those living with MS. I'm sure they've seen this or read this online and talked to their neurologist about this. But the central nervous system is made up of the brain, which is what really separates us from other animals, non-human animals. It gives us the voluntary control and the thinking that we need. But included within the central nervous system is the brainstem, which is those three little parts that you see highlighted in the blue oval. And behind the brainstem and underneath the brain sits the cerebellum. And then finally, we have the spinal cord. And each of these components or parts of the central nervous system control specific functions. So, for example, the brain, as I mentioned earlier, is important for voluntary movement. The brainstem controls all of the reflexes that we really don't think about in a day-to-day setting. So, for example, blinking, you don't think about blinking, or breathing, you don't think about breathing, or even swallowing, sometimes you don't think about it, it just happens. And that happens because of the reflexes within the brainstem. Our cerebellum is very important in terms of walking and coordination. And then, of course, the spinal cord is what delivers the nerves that we need to be able to move all of our body parts. So all of this together is what makes up the central nervous system. Now, if you look at a little bit more of a microscopic level of the central nervous system, what you'll see is that the cells of the central nervous system are called neurons. And these neurons, as you can see in this cartoon, are made up of the cell body. And then you have the axons, which is, you can think of this as the trunk, a tree trunk. And then the end of the axon are dendrites, which are these branching sort of finger-like projections that then often synapse or connect to either another cell body or neuron, or may go to a specific muscle that allows us to be able to move either our eyes or part of our body. If we look more carefully at the axon, what you'll see here in this cartoon is that the axon, which is actually the nerve fiber itself, is surrounded by an insulation layer which is made up of basically fatty tissue that's called myelin. And the axon is what transmits information from cell to cell or cell to muscle. And the myelin acts as a protection of the axon to help with the transmission of information. So not only does it help that electrical propagation within the axon, but it also provides it nutrition and protection to keep the axon healthy so that we are able to do the things that we want to do and for the central nervous system to work properly. Now, what happens in multiple sclerosis? Well, this cartoon drawing, of course, looks quite complicated, and it is. And it is meant to show you how complicated multiple sclerosis is. And even as complicated as this diagram is demonstrating, believe it or not, it's even more complicated than this. And in fact, there are many steps within the process of what happens in multiple sclerosis that we still don't understand. One of the things that we really don't understand is what actually causes multiple sclerosis, what initiates the initial event, as well as all the other cascade of events that ultimately result in the development of multiple sclerosis. So really, what happens in multiple sclerosis? If we break it down, what happens? Well, this is a cartoon that sort of puts into a simple context of what we believe is happening. So the fish there, as you see, which is labeled the T cell, is a specific immune cell that we all have in our body. And for some reason, this T cell is activated. And when it's activated, it rings the dinner bell. And what that does, and in real life what it does is it releases some chemicals which then circulate in our body, and this results in activation of other immune cells, and in this case it would be a macrophage. And this macrophage, which is this big fish, is looking to eat something once it's activated. And in the case of multiple sclerosis, what it attacks, or when it's activated, it starts to eat away at the myelin sheath. And as we talked about previously, the myelin is what protects the axon and what allows the propagation of electrical activity through the axon. So you can imagine that once this myelin sheath is eaten up by this fish, what happens is the axon is vulnerable to damage, and when the axon is damaged, that's when we start having neurological problems. But at the same time, when the myelin is damaged, there will also be neurological problems as well. Now, one thing to understand, and let me just go back for a second, is that our body has the capability of remyelinating. Now, it may not remyelinate back to 100%, but our central nervous system can remyelinate. Unfortunately, axons cannot regenerate. And so what we believe is happening in some patients who have multiple sclerosis, who end up with permanent neurological disability or permanent vision loss, as we'll talk about, it's not so much that the myelin is destroyed, it's rather that the axon is permanently destroyed. And even though the myelin may be able to come back, because there's no underlying axon there, you end up with a permanent neurological problem. Now, in terms of diagnosing multiple sclerosis, there are many ways to do it. Frankly, it is a diagnosis based on the history and examination, so it's a clinical diagnosis. But our ability to make the diagnosis of MS has improved substantially with the development of multiple sclerosis, and I think many of you who are listening in on this webinar have undergone an MRI. It's really a vital tool that neurologists and neuro-ophthalmologists use in making the diagnosis of multiple sclerosis, and truly it has revolutionized and helped us better understand what's going on in multiple sclerosis. Now, let's go to the eye itself and vision. Now that we have a sort of a basic understanding of what happens in multiple sclerosis, let me give you a little bit more statistics. It's been said that 80% of patients or people living with multiple sclerosis will have visual impairment at some point in their lifetime. In fact, 50% of people living with MS, vision problems will be their first manifestation of the disease. So before they have any weakness or difficulties with walking or fatigue or problems thinking, it's actually vision that brings the person to the doctor's office and then sets this cascade of events that ultimately leads to the diagnosis of multiple sclerosis. So an eye exam can be so important in people living with MS, and even those who don't have MS but then present with eye findings can often lead to the diagnosis of multiple sclerosis. And let me just go back for a second and share with you this cartoon drawing, which actually sort of drives the point home and emphasizes the fact that the reason vision problems occur so often in people living with MS is because the optic nerve, which is the cable wire, and we'll talk about this, that connects the eye to the brain, is really a part of the brain. So it is a member of the central nervous system. And because it is part of the brain and because multiple sclerosis targets the brain, that's why vision problems so often occur in people with multiple sclerosis. Now, what are some of the eye symptoms that people can have? Well, some of these eye symptoms that we've listed for you here on this slide are very common symptoms that people who don't have MS can have. So not everybody with blurred vision has MS. Of course, not everybody with decreased vision has MS. There could be many causes for that: cataracts, macular degeneration, some cornea problems, things like that. Black spots in vision also is not specific for multiple sclerosis. In fact, it's very common in people with floaters. Poor color vision, poor depth perception, eye pain, double vision, or wandering, or what people call lazy eye, or even jumping vision, all can be symptoms of multiple sclerosis, but each one of these symptoms doesn't necessarily mean that the person has MS, because there are other things that can do this as well. And so that's why it's important when a person has an eye problem to go see an ophthalmologist or an optometrist to be able to identify exactly what the problem is and see if there's anything in terms of the eye exam that can that can make the diagnosis and give the physician an idea of what's going on. And as I said previously, the diagnosis of multiple sclerosis is really based on the clinical examination and history. Now let's look at the eye a little bit more, and I think many of you do understand how the eye works and what the anatomy of the eye, but I thought it would be a good refresher to go over this. The eye has a number of components, and if you look here at the drawing on the right side of the slide, you'll see a cross-sectional view of an eyeball with the cornea sort of lifted. And starting from the left and moving our way to the right, if you were to imagine a ray of light going through the eye, the first thing that light would hit would be the cornea, which is the clear glass, if you will, of the eye that transmits and focuses light. When you look at a person's eye, you'll see the color part of the eye. That's called the iris. That's what gives the color of the eye. And that iris, in the middle of that iris is a hole, which is known as the pupil, which is the black part of the eye that you see. And really the pupil is a non-structure. What I mean by that is just a hole or an opening within the iris that does move. It can get bigger or smaller depending upon the amount of light that's being shown into the eye. So it really regulates the amount of light getting into the eye. Now behind the pupil in the iris sits the crystalline lens. The lens is what really allows us to be able to focus at distance and near, and as we grow older or mature, that lens can then become a cataract, which happens in almost everybody as we mature in life, so it's not just specific to multiple sclerosis. And then that white arrow points to the light finally hitting the retina, which senses the light and creates an electrical impulse, which is then sent through the optic nerve to the brain, which we'll talk about. Now, within this major cavity, which is labeled here as vitreous, which is 4/5 of the volume of the eye, we have a jelly that really keeps the integrity of the eye in place. In terms of what happens from the optic nerve, well, if you think about the eye and the brain, you can almost think of it like the television set that you have at home. The eyeball would be the TV set, your optic nerve would be that cable wire, and your brain would be the signal sent from the cable company. So what happens is that the eye captures information from your environment. It then converts it into an electrical impulse from the light waves from the retina, and then from the retina it goes through the optic nerve and to the brain, where our brain is able to interpret our environment. So what I'd like to remind people is that we actually don't see with our eyes. We actually see with our brain. Our eyes and the optic nerve are only an instrument that allows light and our environment to be processed by our brain. Now moving on, now that's how we see. How do we move our eyes? Well, believe it or not, that is a completely different system. So here is a cartoon drawing of on a side view showing you the muscles, or what we call the extraocular muscles of the eye. They start from the back of the eye socket and they move forward. This is represented by those red lines that you see there. And we actually have 6 muscles to the eye that move the eye in all different directions. And as you can see, in the middle of these muscles, from the eyeball, and you don't see the brain here, is the optic nerve. So remember, that's a completely different system, and what we're now talking about is how the eye moves. The movement of the eyes is actually controlled by nerves that come from the brainstem. We talked about earlier, the brainstem is part of the central nervous system. So we actually have 3 specific nerves that then go to those 6 muscles that allow the eye to move. But we have 2 eyes. So how does the right eye know what the left eye is doing, and how does the left eye know what the right eye is doing? Well, that's controlled through the brainstem. As you can see in this cartoon drawing, we have an octopus, and that octopus is moving is able to control the eyes through the brainstem so that the right eye and the left eye know what they're doing. Now, when you have a lesion, or if you have a MS attack that affects the brainstem, this will affect the way the eye moves. And as a result, you may have double vision, or you may have nystagmus or dancing eyes. So very often a brainstem lesion in MS results in abnormal eye movements, resulting in double vision or nystagmus or dancing eyes. But the most common visual problem that people living with MS face is optic neuritis. Optic neuritis means an inflammation of the optic nerve. It is the initial manifestation of multiple sclerosis in up to a quarter of people. It is characterized by rapid, usually one eye, painful loss of vision. The vision usually recovers within 6 to 8 weeks, thankfully. And when the vision recovers, it recovers in most people. But often, people will have a problem with their vision, and they will notice that the vision never returned exactly back to normal. And so there are a lot of causes of optic neuritis. Multiple sclerosis probably being one of the more common, but as you can see here, I've listed for you other things that can cause optic neuritis. So when you go see an optometrist, ophthalmologist, or neuro-ophthalmologist, and they think you have optic neuritis, very often they may do blood work to exclude these other possibilities. This picture that you see here of the back of the eye is a patient who actually had cat scratch disease, and those yellow things that you see in the middle that look like a star represent a specific type of optic neuritis known as neuroretinitis. But again, as you can see on the right side of the slide, there are many causes of an optic nerve problem, and it's just not multiple sclerosis. So this happens to be a painting or a drawing that a patient of mine gave me when she was having a bout of optic neuritis in the left eye. And here you can see on the right side of the slide is a beautiful bouquet of flowers that was sitting on her hospital table. And on the left side is what she saw out of her eye with the optic neuritis. Now, fortunately for her, she did very well and she recovered. But even when she recovered, and she drew for me this petal to show me what she was experiencing, what she said to me was that, look, Dr. Body, my right eye is doing great. That's the eye that didn't have optic neuritis. But my left eye, even though my vision is almost back to normal, I still don't see colors as brightly. So she colored this a little bit darker, and she said, I just don't see the details as well as I do out of my right eye. And that's very often what happens to people after a bout of optic neuritis. They will improve, but often they'll notice that there is still a slight difference between the two eyes. This is what an eye doctor will see when looking behind or into the eye. On the left side is what a normal appearing optic nerve looks like, and then on the right side is what an optic nerve looks like when it's swollen from optic neuritis, which occurs in about 1/3 of people. And then with time, this just happens to be another patient of mine, but with time, what happens is that in this case, if you look to the right side of the slide, that's a normal appearing optic nerve with that orange-pink appearance. But this patient had optic neuritis, and even though she improved, there's that footprint that's left behind where the optic nerve looks pale. And some of you may have heard your eye doctor say that the optic nerve looks pale, and that's what they mean. The optic nerve does not look as orange or pink compared to the other eye, and that is a result of the optic neuritis resulting in some permanent damage to the appearance of the optic nerve. Now, in terms of treatment for optic neuritis, it's based on a clinical trial that was done in the late 1980s, early 1990s, called the Optic Neuritis Treatment Trial. The bottom line of this trial was that if a person who did not have a history of MS presented with optic neuritis or had optic neuritis, you need to do an MRI to gauge their risk of developing MS. Also, this study showed that giving IV steroids or intravenous steroids for 3 days followed by a 2-week course of oral prednisone accelerated the recovery of vision but did not have any long-term benefit, meaning that after a year, whether you gave steroids to a patient or not, the vision would be what it would be. But by giving the intravenous steroids, the vision came back quicker. And the third, and really a very important thing that we learned from the optic neuritis treatment trial, was that we should not give patients just oral steroids by themselves. Because in this trial, when those patients who received oral steroids, we found that their risk of developing another attack of optic neuritis actually doubled. So as a result now, when I see a patient with optic neuritis, I offer them either nothing and tell them that their vision will improve. It'll just take some time. But if you want to accelerate the recovery of vision, we can give you IV steroids for 3 days. There is a symptom that occurs after one recovers from optic neuritis. That's called UTOP symptom. It's named after a German ophthalmologist. In this case, what happens is if a person who's had optic neuritis and recovers, takes a hot shower, a hot bath, or exercises, or gets angry, anything that increases the body temperature can cause a transient blurring of the vision. And I like to remind my patients who have had optic neuritis not to get scared, not to panic. You're not having another bout of optic neuritis. If you just cool down your body temperature, your vision will return back to normal. That's called UTOP symptom. There is another symptom or phenomenon that people can experience after having a bout of optic neuritis. That's called Pulfrich Phenomenon. In this case, what happens is, because the optic nerve is damaged, the signal going from the bad eye compared to the good eye is slower getting to the brain, and as a result, people will see things that are swerving rather than coming straight at them. And so that can make driving difficult, make walking on uneven paths difficult, and make even recreational activities such as playing baseball or tennis or volleyball very difficult, because objects that should be coming straight at you appear to be coming at a angle or a curve, and that's called Pulfrich phenomenon. So in conclusion, hopefully I've been able to show you that the ability to see and move the eye is very complex. The eye is intimately connected to the brain, and that's why it is often affected in multiple sclerosis. And multiple sclerosis can cause optic neuritis, which is the most common eye manifestation of multiple sclerosis, but can also cause double vision and or nystagmus. And that steroids, in particular intravenous steroids, can accelerate the recovery of vision. And we won't tackle this topic today, but also those FDA-approved multiple sclerosis drugs are very helpful in reducing the risk of multiple sclerosis. So with that, I want to thank everybody for their attention and time. It certainly, again, was a privilege. And now I'd like to turn the webinar over to Dr. Diane Whitaker, who will discuss the visual rehabilitation aspects of multiple sclerosis. And again, thank you very much.
Well, thank you, Tarek, for that introduction, and thank you for doing such an excellent job of sort of describing the visual system so that people can really understand where these frustrating limitations come from should you experience neurologic problems from multiple sclerosis that impact your vision specifically. By the time people get to me, they've already undergone maximum medical therapy. So I see people that have either chronic or permanent visual limitations from disease. So I'm not going to see someone in the acute phase, because hopefully they're seeing a neuro-ophthalmologist in a timely manner so that they will have access to the excellent treatments that we have that do expedite recovery and get people back to seeing better. So when I do get to see these patients in my own clinic, I know that I'm working with permanent conditions, and so I'm not able to restore anything that's lost, but the goal of my interventions and my team's interventions are to help people make the best of their remaining vision and to limit the frustration that their visual limitations cause in their everyday activities and their quality of life. So Dr. Bhatti described very well that when eye muscles are not working properly, you can have a host of different problems. And the more common problem that I see in my clinic is diplopia or double vision. And sometimes this is something that is transient and it goes away, and there are a couple of ways to treat double vision with eyeglasses, and specifically something called a prism can be applied to eyeglasses temporarily to help align the two separate images that an individual is seeing so that they don't have that bothersome double vision, and that they can have more comfortable single vision until the condition resolves, if it does resolve very quickly. One of the options for prism is a press-on prism that's shown in the photograph called a Fresnel prism, and this is actually a photograph of Hillary Clinton, and she has a prism on her left eye. And you may not be able to see it well from the image, but you press this on the back side of the eyeglass lens. It has little ridges that create a prismatic effect, and you can put different magnitude or power of prisms into a spectacle lens depending on the magnitude of the deficit. So meaning the larger the separation of the images, the more prism needs to be prescribed. The beauty of this press-on prism is it's not permanent, so it can be removed. So as the deficit or the magnitude of the deviation gets smaller and smaller, you can gradually decrease that amount of prism, and eventually if it resolves completely, the prism can be removed, and there's not a lot of expense involved in that. Some people cosmetically don't like the way that it looks, and it does degrade the quality of vision just a little bit in the eye that it's placed in front of, but in general, most people are willing to tolerate that. The second option is something called ground-in prism, which cosmetically you can't see usually other than added edge thickness to the lenses, but it is clear and cosmetically more acceptable. The downside to grinding in prism is every time you change it, you have to visit your optician, and that's going to cost you more money to regrind different levels of prism as your condition continues to change. Sometimes people will patch or occlude an eye if the deviation is large enough. Most people try to avoid that, but those are some of the things that we can offer to people that are experiencing double vision, because it's very disconcerting and it keeps people from being able to function in a very remarkable way. So it's definitely something that we have to address. The second issue that I don't see that much is nystagmus, which is moving eyes. And when I do see this, because this is an acute onset of nystagmus instead of something that's been someone's born with, which has a different sort of clinical presentation, a different functional limitation, this can be very, very also disturbing to the patient that's experiencing it, that normally has never had experienced anything like this. So we try to do things to help minimize the impact of the motion, and a lot of times when patients have a movement or a motion of their eyes, there's a face position or a head posture that they can find, which is called null point, that will minimize some of that rotation or that motion. So we try to help identify that if it hasn't already been identified by the neuro-ophthalmologist. Like I said, I'm very fortunate that I don't see much of this, because I'm usually seeing patients that have already sort of processed through this phase of the spectrum. What I do see consistently and chronically is permanent central vision loss that's the result of optic neuritis in one or both eyes, more commonly in one eye. And when you have central vision loss, this can be very challenging functionally, because our central vision controls our ability to see color and fine detail discrimination. So people will come in classically complaining of inability to read fine print, difficulty recognizing even their friends' faces from long distances. They might stumble on steps or curbs, especially a curb the same color as a sidewalk or the last step in a flight of stairs. And they'll confuse numerals like 3s and 8s and 6s and 5s. So if they have, a small deficit even in one eye, it can make doing fine detailed tasks exhausting, frustrating, and more time intensive. So these people will be complaining of eye fatigue. When you have central vision loss in one eye, one of the other things that people will mention is that things appear to move on the paper. And this is not the same thing Dr. Body was talking about when the eyes are actually moving from nystagmus or from double vision, but this is something that the brain does to compensate for a central vision deficit called eccentric viewing. The brain doesn't want to see blur. It doesn't want to see blank. It wants to see clearly. So you have this sort of involuntary compensating mechanism of moving your eye around that deficit so you can see the object of interest. So when that happens, if you're reading, you may feel like the words, different letters in the word will pop in and out of your vision if that little central imperfection is obscuring that part of the word at that time until you make a corrective eye movement. What we know from studies of people that have central vision loss from any eye condition is that they make 10 times more eye movements when they read than normal, and that's where the fatigue factor comes in. So you can imagine if you're moving your eyes 10 times more than you'd have to, reading's not going to be pleasurable anymore. It's going to take more time. You're going to make more mistakes. And a lot of people say, Dr. Whitaker, I feel like I'm reading at first grade level again. So that's probably the most common complaint that I have. The upside of central vision loss is it responds extremely well to magnification and contrast enhancement. And before I get into that, I kind of want to talk a little bit about the images that I have on the screen. The top one is a printout of the visual field that many of you that have had optic neuritis have had, and maybe your doctor has reviewed this with you. But the image, if you look at the two circular images, the image on the right-hand side has two dark spots. That outer dark spot is our normal blind spot, and it corresponds with the one on the left eye. But the one that's closer to the center is a deficit that we would see commonly with a chronic optic neuropathy or optic atrophy from repeated optic neuritis. And if you look at the image below, how that would translate in the real world is if you were looking out into the world with that. I don't ever have a patient, no matter what their diagnosis is, that causes central vision loss, or I shouldn't say ever, but very rarely do I have a patient that says they see a black spot. 98.5% of the time, people with central vision loss say it's blurry, I have a cloud in my vision, it's hazy, it's just not clear. So we call them blind spots, but they're not truly blind from the patient's perspective, at least not from the way patients describe it to me routinely. So we talked also, or Dr. Body talked also and showed those beautiful illustrations from his patient that did those drawings, and I think that was an outstanding way to sort of introduce this concept. But what we see in the acute phase, and we actually use the red top test clinically when we're trying to roll out an optic neuropathy, is to see this sort of what we call desaturation to red. So in an eye that's affected by central vision problems, the colors would be duller, which was shown in the that beautiful picture of the red flower. And so it's not that people stop seeing in color, it's that their color perception is altered, and it's not the same as someone with normal color vision would be, and it's not usually the same as the other eye, if the other eye is normal. And it makes things in the real world a little more challenging. And some examples of that are if you take several medications and you identify your medications by the color of the capsule or the tablet, sometimes you might start confusing ones that you would recognize by the color. In eye care, we do a lot of eye drops, and most patients don't know the names of their drugs, but they know them by the color of the top. So if they have a burgundy color top and a red color top or a purple color top, they may not clearly identify that medication after they had an episode like this in the affected eye, because those colors will be confused. So it's not like they say, oh, that looks black or gray. They just think that colors that have the same intensity but slightly different hue are very confusing to differentiate. So the classic example is when they're dressing themselves. Are the pants or the socks black or navy? Is the shirt maroon or is it brown? And so it's not that they can't tell that it is a color, and they can even tell that like I said, the intensity of the color, but if the intensities are similar, it's making that judgment call. Something I think that's interesting, I'm not a big cook myself, but many of my patients that love to cook, one of their biggest frustrations they tell me when they have central vision loss is when they're in the kitchen, they can't tell, especially if they're preparing meat, if it's done or not. They can't see that subtle change in the color as the meat is heating and becoming less red or less pink to know if it's done. And so a lot of times they tell me they end up burning their meat or burning their food. So those are some of the practical things that people will complain about if they have color vision issues related to optic neuritis. Dr. Bassi also talked about the different types of depth perception issues, and I really want to focus on the depth perception issue, not so much from the Pulfrich Phenomenon, which is sort of an interesting thing by itself, but more from the fact that if you have one eye that has poor central vision and the other eye still has pretty normal vision, your sense of depth perception can really be thrown off. Depending on the magnitude of the central vision loss in the affected eye, the more severe, the bigger the impact will be on depth perception, because our brain relies on input from both eyes that's fairly equal to make judgments about distances. And so what I tend to see, the biggest complaint for patients, especially patients that have significant central vision loss in one eye only, is driving. And they say, you know, I can't pull into a parking space without bumping into the other car. I pull too far forward or not far enough, and I'm having all these fender benders because I can't judge distances anymore. And at night, this is exponentially worse, and many of these patients will stop night driving, or they'll limit their night driving, or they're driving in inclement weather when there's lower illumination for the same exact reasons, because their confidence is so much lower. We mentioned, both of us, Dr. Body and I, that steps and curves are difficult. They're difficult because they're low contrast, meaning it's hard to see where one step starts and another one, like especially the last step. If the last step is the same color as the landing or the threshold, you're not going to see that if your depth perception is not optimal, or even your visual acuity is not very good. And that's why putting markers on the last step or on a curve that's just the same exact color as the sidewalk is so helpful. The problem is you can do that in your own personal environment, but you can't do that in unfamiliar places. You can't go to your neighbor's house and start putting tape on their stairs and things like that. So knowing that contrast makes a big difference can help prevent problematic falls. The other issue is that people just look at these patients as being super clumsy. You can't look at an MS patient's eyes and know that anything is visually wrong with them. And so people have this misperception about visual impairment, that you're either Helen Keller blind and you see nothing, or you see perfectly. And 98% of the people that I deal with are partially sighted, meaning they're somewhere on the spectrum of visual impairment, meaning they have some usable vision. Now, that can vary greatly from one person to the next, but they have something to work with. And so if you can't look at someone's eyes and tell that there's nothing wrong with them, then people just perceive that you're rude or clumsy if you don't recognize them at the grocery store. And it could be because you didn't recognize their face because you couldn't. And they'll call you out and say, hey, I saw you the other day, you were rude to me. And that creates a tremendous amount of psychosocial distress for many patients. The other issue with this is especially with acute onset of vision loss in one eye, is you may be reaching for your coffee cup and totally miss it. Or more commonly, you think you're pouring coffee into your cup and you're actually pouring it onto the side of the table. Once again, you look clumsy, but the true issue is your sense of depth perception is not what it used to be, so you're making reaching and grasping errors. So when you have this sort of challenge, it makes judging any sort of distances difficult, and if you turn the lights down, it's even harder. So my job is what can we do to sort of minimize these things that are creating frustrations and limitations and making people look clumsy or socially awkward, and how can we sort of get them back into mainstream life, functioning at a level that feels acceptable to them? That's really the crux of all of our interventions and our team approach. So I mentioned that magnification is super helpful for central vision loss, and the whole concept behind magnification is we can't eliminate that central imperfection. However, if we make the information that we're trying to see big enough relative to that deficit, then we effectively make that deficit smaller and we limit its impact on ability. For instance, if you're reading and you have a deficit that covers, half of a word, that's going to make it really hard and slow to read. But if you make the word so much bigger that now you're just partially obscuring, that deficit can only partially obscure maybe a single letter, your reading speed and accuracy is going to go up significantly. So the way magnification works is it just gives you more visual information to make decisions and to get information. So magnification can come in different forms. 20 years ago when I started doing this, people thought of a magnifier as, the thing that Sherlock Holmes holds in his hand. It was very unsophisticated. It wasn't lighted. You hold it above a page and makes things look big. Magnifiers today are really mainstream devices. I very seldomly will prescribe a traditional handheld magnifier. And the reason for that is that mainstream platforms like smartphones, tablets, and even computers have these fantastic cameras that can do an amazing job of magnifying and providing contrast and lighting. So you've got this tool that you probably have in your pocket or your handbag with you all the time that you didn't even know could be your new best friend. It can help you read. There are apps that you can download to your smartphone that turn into a lighted magnifier, apps that you can download to your smartphone that will actually read text, so it could read a menu out loud to you or read ingredients on the side of a can. So apps and smartphones are really the tools of today and tomorrow. And like I mentioned, I very rarely do traditional magnifiers. Traditional magnifiers are for my older population who maybe inherited a magnifier from their parents or from their spouse, and in their mind, a magnifier is a magnifier, and they don't want to mess with smartphones. But for the young people and the vocationally active people that would be more likely impacted by multiple sclerosis and optic neuritis, your smartphone can be your best friend. The other thing you can do is just make your screens larger, so having a bigger phone is better. If you have a laptop computer, connect it to a TV monitor or to a larger monitor, you will see it better. Because anytime you make the image of what you're trying to see bigger on the retina, you're going to be able to process that information more effectively because you're minimizing the impact of that central vision loss. So larger screen size, simply viewing something closer. So I have patients that say, I can't see the scrolling text on the TV. I can't read the menu or the guide. And I ask them, well, how big is your TV? Next question is, well, how far do you sit from it? And then once they tell me what those numbers are, I say, we have two choices. You can pick your chair up and move it closer to your existing TV, and you'll see it a lot better. Or you can keep your chair where it is and buy a bigger TV. One costs a lot more money than the other. And anything that we can offer in the clinic that stimulates seeing the television better is basically just recreating this phenomenon of relative distance magnification. So sitting close to the TV will not damage your eyes. That's an old wives' tale. If you want to see the TV better and you have central vision loss, sit closer, and that won't cost you anything. When you need to have better distance vision and you can't get closer to the object, like when you're driving a car and you need to be able to pick up a traffic signal at a reasonable distance or read an exit marker or any kind of signage, you can't get right on top of it because then you don't have time to make a good decision. So that's when telescopic lenses can be incorporated into traditional eyeglasses that give you distance magnification. I've mentioned that contrast is equally important as magnification. So much of what we look at, even on this PowerPoint presentation, the purple writing against the white background is not as easy to see as the black writing is against the white background. And the MS at the bottom corner is not as easy to see as the purple is. So having 100% contrast, pure black on white or pure white on black, enables you to see better when you have central vision loss. And our screens will allow us to do that. So there are settings in our computers and our phones and our tablets that allow us to set maximum contrast. Lighting, huge, full spectrum or daylight type lights make a big difference in color perception and in detail discrimination. That's why artists routinely use these. Even people with great vision appreciate full spectrum lighting because they understand the importance of having how much the right kind of light can make you or break you. I mentioned that there are apps for magnification. There are also apps for contrast, and what I'm showing you is a live screenshot from Apple Accessibility. So for those of you with iPhones, if you go into your general settings, excuse me, and you scroll down to accessibility, you'll see a screen that looks just like this. You can control magnification, contrast. Large print means everything will be bigger. So your text will be bigger, your contacts will be bigger. Zoom is sort of self-explanatory, meaning you can zoom as needed. And voiceover is a screen reader, so that's something that would actually read something out loud to you that you're trying to read or view. So the color vision issue is a little bit harder because there's no magic sort of thing to make your color vision go back to what it was. But there are cool color ID apps. So for instance, and these are usually free, you can download to your Android or your iPhone a color ID app, and if you're shopping for clothes and you're trying to decide, well, what color is this dress really? You just aim your phone at it, it'll read it, it'll say this is magenta or whatever, and There are different color ID apps that are much more descriptive and some that are very basic, but a lot of these are free, so check those out online. Actually, this is an image of such an app working on the right-hand side of the screen. There are certain filters that can help enhance color perception a little bit, specifically if you have a certain color deficit. That gets pretty technical. I'm not going to get into all the specifics of that, but you're an eye doctor that specializes in rehabilitation can sort of lead you in that right direction. We talked about altered depth perception, but we didn't really talk about how we can remediate that. And this is where an occupational therapist is such a critical part of my team, because occupational therapists are people whose professional sort of emphasis is hand-eye coordination, balance, falls prevention. And when you have an occupational therapist that's cross-trained in visual impairment, you've really got a super powerful player for the MS patient, because unfortunately many MS patients have physical motor limitations. So they already have challenges with balance and stamina and walking, and you confound that by visual impairment, and you create sort of the perfect storm for falls and for other accidents. So having an OT that's qualified to address all those issues in its totality is super important. One of the things that we teach people to do is use non-visual cues for hand-eye coordination techniques. So for instance, if a patient is having an issue reaching for their coffee cup or pouring their coffee, we'll teach them to hold the cup with one hand, hold the coffee cup with the other hand, and actually close their eyes. So they're not using any vision to guide the coffee mug or the coffee dispenser to the coffee cup. No, we're not asking them to pour it yet. We're just asking them in visual space, knowing where one fist is compared to the other. Because of the tension in our joints and our muscles, we can, with our eyes completely closed, we can make our two fists come to each other pretty accurately because of proprioception. So we teach people to use non-visual cues. The occupational therapist will do a complete, what's called a functional mobility assessment, which will be strength, stamina, balance, and then with the underlying visual issue being understood as well. She'll talk about contrast and lighting, because that's important in depth, as we talked about before. And that for people that, and this doesn't happen in MS, but for people that have almost no vision in the affected eye, there are monocular visual cues that we can teach people how to use that don't rely on any input at all from the second eye to be able to judge distances. And those are called motion parallax and linear perspective. So in closing, about a third of individuals with optic neuritis secondary to multiple sclerosis will have persistent visual symptoms that adversely affect their quality of life. And these are the people that I see routinely. And these deficits can be anything from having issues with low contrast targets, so color on color, tone on tone. They can have color vision challenges that we've discussed. They'll have vision worse than 20/40 in the affected eye, and they'll have that sort of persistent visual field deficit. Vision rehabilitation is super helpful for anyone that's struggling in this area, because we can help. We can't restore what's lost, but we can help improve quality of life by reducing frustration, reducing the limitation, increasing independence, and really just trying to overall improve your overall, as I think the mission, one of the missions of Can Do MS is just to help people live productive, happy lives. And that's really what rehabilitation is all about. One of the things I'd like to say, because there aren't very many people who do what I do, so it might be hard for you to find a vision rehabilitation specialist in your area, but look for them online, and you can Google that under vision rehabilitation, low vision rehabilitation. But anyone that has progressive or relapsing optic neuritis should ask their doctor to refer them to vision rehabilitation, because I think we have something to offer everyone. Thank you for your time.
Terrific. I want to thank Dr. Bhatti and Dr. Whitaker for providing a comprehensive overview of vision issues and practical solutions on how to deal with these issues. We do have some time for some questions and answers. So I'm going to start by asking Dr. Bhatti, first of all, looking at eye exams, how often should one get an eye exam? And then when they decide that an eye exam is necessary, who do they see? Is it an ophthalmologist? Is it an optometrist? What does a person who is experiencing some eye issues and knowing they've been diagnosed with MS, where should they turn and where should they go?
Yeah, that's a great question. So the American Academy of Ophthalmology has some guidelines as to when an eye exam should be performed. But for those people who really don't have any health issues, who are not having any eye problems, and are relatively young, it's a good idea to get a baseline eye exam just as a screening test to make sure that they don't have any unrecognized vision or eye problem, for example, glaucoma, which doesn't cause any pain and usually is asymptomatic in the beginning. So certainly if you have a family history of any eye problems, or if there's any concern, it's always a good idea to see either an optometrist or an ophthalmologist. Now, in terms of those people who have been diagnosed with a specific disease, as in this case, multiple sclerosis, you can, and if you're not having any vision problems, I think it's a good idea to get a baseline eye exam in case you do have a problem in the future. Your eye doctor can go back and look at what was done previously to see if there's been any change. But certainly if a person who has been diagnosed with MS and is having vision problems, I would recommend, if possible, to see a neuro-ophthalmologist. And I say that because many a times an ophthalmologist or an optometrist may not feel comfortable doing the exam knowing that the patient has a specific neurological problem. And often what I found is neurologists will often refer me patients that they have diagnosed with MS or some other neurological disorder, so that we can do not just a comprehensive eye exam, but do some extra testing that we do in the neuro-ophthalmology clinic, such as peripheral visual field testing, a test called optical coherence tomography. I will also review the MRI of these patients. So it's a neuro-ophthalmologic examination is different from an optometrist or an ophthalmologist examination, not only in just the test that we do, but the perspective of how the data and how the patient is examined. As Dr. Whitaker said, there's not very many of her specialty, and I certainly can appreciate that. I'm very fortunate to have her working at the Duke Eye Center, and we often refer patients to her clinic for help. But there's also seems to be a shortage of neuro-ophthalmologists in the community. So if there is not a neuro-ophthalmologist in the community, then certainly a qualified optometrist or ophthalmologist should be able to make the basic diagnosis. And if there seems to be still some questions, then that eye care professional can refer to a neuro-ophthalmologist, which may require a little bit of distant driving. But ultimately, we should start with seeing a general ophthalmologist, optometrist, and then work your way up to a neuro-ophthalmologist. If you can't get the answers that you need.
Terrific. Dr. Whitaker, I realize that you see patients once they have developed serious symptoms, but can you tell me if there's any preventative measures that one can take if they have been diagnosed with MS and think that they might incur or occur vision problems going forward?
I can't really think of anything preventative that you can do because you just don't know where the disease is going to attack. I mean, at least at this point, we don't have a way to look for where these areas of inflammation are going to arise, and so you can't really do it from that perspective. One thing that I would like to add to what Dr. Bhatti was saying is, and we actually have a shared patient that we both have seen within the last year who's a young man that was coming in with normal vision, complaining of just sort of generic blurry vision at near, and he was a pharmacy student in pharmacy school, he was having such a hard time keeping up with his reading, but he saw several optometrists and ophthalmologists, and everyone kept saying he was fine, he was fine, he was fine. And yeah, we found some mild binocular vision issues. His eyes weren't working perfectly together, but nothing really that stood out. And within about 8 months of that, my last visit, he was diagnosed with MS. And so here's a young man that's still communicating with me saying, you know what, I saw another neuro-ophthalmologist at another university, and I saw another ophthalmologist somewhere else, and I don't know if I should finish pharmacy school or not. I don't know if I'm going to be able to do it. So he was asking me basically the same question. Is there anything I can do to prevent this? Is there anything I can do to feel comfortable moving forward in a profession that's highly visual if I know that I may be plagued, with some vision problems, if 80% of people are going to experience this at some point in the course of their lifetime and in the course of the disease? We don't have a crystal ball. We can't really answer those tough questions. And so I counseled him to the best that I can. I said, ultimately, only you know if you can finish pharmacy school, but I can't make you any guarantees. I can't make you any promises. All I can say is that as things arise, we can stay on top of it. I think the best thing you can do is just be aware once you have that diagnosis of what can happen. I think that's why this seminar is so important, is to know what the potential visual things, what the potential visual problems could be that could arise that are associated with MS. So if you start to have it, to go to your eye doctor and not ignore it, that maybe it's something that'll just pass. And so I wish that we could prevent, and I wish that we could predict, but we're just not that good yet.
Laura, if I could just jump in, I totally agree with Dr. Whitaker. I'd just add two things. One is that the only thing that I can think of that could reduce the risk or prevent, not really prevent, but reduce the risk is taking one of those FDA-approved medications. Those medications that one takes either orally or subcutaneously or even intravenously, their job is to try to reduce the risk of having another attack, and that would include an attack involving the optic nerve of the brainstem. So in some ways, taking those medications might prevent the problem. The other thing that I wanted to add, which is quite frustrating for me as a physician seeing patients who are having visual complaints, is, I'm at the mercy of the sensitivity of my tests. And so there are often, I see patients who have visual complaints, but yet I can't find anything on their neuro-ophthalmic examination to explain it. And what I tell patients is that, they'll say to me, well, maybe, do you believe what I'm telling you? And I say, of course I believe what you're telling me. It's just the problem is that I'm not able, based on the test that I have, to be able to detect it. And to be honest with you, this sort of came to light for me when we started using this technology called OCT and using it both in research and clinical practice. What we found was that patients who had 20/20 vision with MS, who we used to say, your eye exam is normal, now using this test, we've actually found that they actually have subclinical disease that was so difficult to detect, and even now is still very subtle, but there certainly are changes going on in the optic nerve and the visual pathways that were so subtle that we weren't able to see it prior to this new technology. And I think as we move forward and develop newer technologies and have a better understanding, we will find more subtle things that can explain some of the patient's symptoms that currently we're not able to explain, which is very frustrating for both me as a healthcare provider and, of course, the patient herself or himself.
Dr. Body, when you mentioned FDA-approved medications, are these medications you're referring to specifically for vision issues, or are they the general MS medications that you're referring to?
Right. So these are the general MS medications, but when we talk about reducing the relapse rate, those relapses include anything within the central nervous system. So that includes the brain, the brainstem, and the optic nerve. So it's not specific to the eye, the visual pathways, but rather to the whole, the entire central nervous system. That includes the optic nerve, that includes the brainstem that can cause double vision. So it is, the visual problems are a downstream effect of multiple sclerosis. So the only way that I know of to try to reduce the risk of a neurological event, an inflammatory demyelinating event, what we call an MS attack, from affecting the optic nerve is to really take one of the FDA-approved drugs.
Okay, terrific. Dr. Barty, I did get a lot of questions about normal aging with eye issues versus MS. So in other words, how can a patient tell when it's just normal aging and when it's a symptom of MS?
Well, that's a great question. So I guess when somebody asks a question about normal aging, we're talking about the normal aging that occurs with the eye, in particular development of a cataract. And the simple answer is seek an eye care professional. Have them look in the eye, do a complete dilated examination, because I think most optometrists, most ophthalmologists should be and are able to diagnose a cataract, which occurs in people as we grow older. But one other thing to understand is that, as we age, we also lose cells, and that includes the optic nerve. So there are some cases where and as we know in multiple sclerosis, the acceleration of loss of cells in the brain is increased in people with multiple sclerosis. So they may have more symptoms as we get older because of the additive effect of age plus the disease. But most cases of optic neuritis are painful, but there are cases that are painless, and most cataracts and almost all cataracts are painless. So a good eye exam should be very helpful in differentiating the two. And frankly, I have had on occasion where a patient with multiple sclerosis who complained of decreased vision was automatically assumed to have optic neuritis by the neurologist, was about to be given steroids, and happened to see me in clinic. And what it was not the optic neuritis, but rather the person developed cataracts, and she was a little bit younger than normal to develop cataracts. But when you took the history, you found out that she had taken a lot of steroids in the past, which accelerates the development of a cataract. So it turned out that it was the cataract from the treatment of MS with the steroids that resulted in her decreased vision, and not optic neuritis. So it was a good thing that we saw her in the clinic, so we avoided her getting more unnecessary steroids, and she was able to be operated upon, have the cataract removed, and actually did very well. So that's just one example of how an eye exam can really help differentiate and sort out what's really going on with the vision. We can't assume that every patient with MS who has a vision or neurological problem is due to MS. You're allowed to have other things causing these problems, and we need to keep that in mind as healthcare professionals and as patients.
Thank you.
Something I would like to add too is the most common cause of vision loss in people over the age of 65 is age-related macular degeneration. And I see a very large proportion of that in my clinic, and these are people that are going to have central vision loss, which I've been describing when I was talking about central vision loss for optic neuritis. So once you reach a certain age, it is an aging disease. Your macula, your central vision doesn't function, and depending on your genetic predisposition and environmental factors, your diet, if you're a smoker, things like that, your risk for developing it earlier in life is there. So to Dr. Body's point, you can have some of the symptoms like central vision loss or blurry vision that you might think, hey, I have MS, this must be that, but it could be something that's either age-related or completely unrelated, and that's why you should get it checked out if you're concerned.
Thank you, Dr. Whitaker. Dr. Whitaker, I would like to ask you a two-part question. Does vision therapy or eye exercises help with MS-related vision problems? And along those same lines, does nutrition play a role in helping with vision loss?
So nutrition and vision loss, definitely we have multiple studies that have shown that eating antioxidants, foods rich in antioxidants are good for retinal health, but not necessarily, there's not anything that we've ever identified that you can eat that's going to give you good optic nerve health, unless Dr. Bhatti knows of a study that I'm not aware of. But we do know that certain, like antioxidants, and vitamins and minerals, are helpful in macular protection. So for the age-related macular degeneration that I was discussing earlier. What was the first part of the question? It was nutrition. What was the other part?
Vision therapy or eye exercises.
Vision therapy, yeah, totally unrelated. So that's a really good question. And, you know, I'm at a center where we don't officially offer vision therapy. We don't use that term for it. It is, and there are different people have different ideas of what vision therapy is and what it's not. So vision therapy for very specific conditions like convergence insufficiency, which is your inability to make your eyes converge when you're viewing in your target. We do have a lot of evidence to support that there are exercises that you can do that will eliminate or improve symptoms. But if you're having nystagmus or diplopia or some of these other severe things that you see in MS, there's not going to be an exercise or a therapy that you're going to be able to do if you're having an acute sort of neurologic event. Vision therapy would not be indicated for something like that.
Did you want to add anything, Dr. Bhatti?
Well, you know, a couple of things. I am not aware of any study that has looked at nutrition and the optic nerve. What I usually tell my patients is that there's no particular diet for MS or optic neuritis. What I recommend is, you know, eating healthy, the normal calories that one needs to get all the vitamins that they need. There are vitamin deficiencies that can cause an optic nerve problem, such as B12 deficiency or folate deficiency. There are toxicities that can occur also from heavy metals and from environmental agents. So, well, I think the important thing is to have a heart. I mean, if you just think about the diet that you need to live a healthy heart health diet, I think that would be great, and that's what I recommend. As for vision therapy, I agree with Dr. Whitaker. You know, if you have a problem with double vision up close due to convergence insufficiency, I think eye exercises can help. But I'll be very honest with you, vision therapy is a very controversial aspect of optometry and of ophthalmology, where I think we still need to do a lot more studies to understand whether these therapies that are being offered, which I don't do at the Duke Eye Center, are really efficacious. Right now, when patients ask me, you know, does it work? First, I say, I don't know whether they work. They may work, they may not work. We just don't have the scientific evidence for me to tell you that. The other thing is vision therapy. It can be quite expensive, and in my experience, having talked to patients, it's usually not covered by insurance. So there is that aspect of it too. So it is controversial. I think, you know, as we move forward in learning more about MS and the eye and other disease processes, I think vision therapy is something that I think more and more of us are looking into in terms of looking at it from a scientific perspective, not just an anecdotal perspective, as to whether it truly works or doesn't work.
Thank you, Dr. Bhatti. So we are actually running out of time, so I would like to ask both Dr. Whitaker and Dr. Bhatti if they'd like to add anything before we close. Dr. Whitaker?
No, actually, I feel like that Tarek and I pretty much covered each other fairly well, which is what we were hoping to do, to sort of start with the disease and finish with the function. And I hope that the audience sort of has the same takeaway that we intended.
Yeah, I absolutely agree. The only thing that I would say in my closing comments is that, you know, optic neuritis and multiple sclerosis became a passion of mine very early on in my career because I would see such patients, and you know, for those who young, healthy people who never had an issue in their life, who suddenly had a vision problem that was thought to be something irrelevant, and next thing you know, I'm telling them that they probably have MS, and once they get the MRI, they do have MS. It was amazing to me to see the resolve of my patients, and how in the beginning it was so difficult for them to hear these two words or two letters of MS, the two words of multiple sclerosis. But what I was amazed was, with time, as I followed them, how well they did. They recovered. They were able to live a very prosperous, very nice life with this small bump in the road, knowing that they'd have to take either an injection or a medicine every day, every other day, once a week, and so forth. So to me, I think it's just an inspiring story of multiple sclerosis, and what's inspired me has really been my patients, and as a result of that, I found an interest in multiple sclerosis and optic neuritis, and it's really a joy and an honor to take care of patients with MS. And as Dr. Whitaker said, hopefully this presentation has been enlightening and entertaining for everybody, and they were able to learn a few things that they hadn't thought about or been taught about before. So again, I want to thank everybody for their time, and certainly I want to thank Can Do MS and the National Multiple Sclerosis Society and the Society of Canada, MS Society of Canada, for allowing us to give this presentation.
Thank you, Dr. Boddy, and thank you, Dr. Whitaker. Before we conclude, I would like to inform you of some additional resources that you may find informative and helpful. On the Can Do MS website, mscando.org, you will find archived webinars, e-news, and library articles. You can also submit a question to the Ask the Can Do team, which will be answered by our team of MS experts. I would also like to highlight some resources available from the National MS Society. They have a variety of brochures and video segments that can be accessed on their website, nationalmssociety.org. The next presentation in our webinar and telelearning series will be on Tuesday, Tuesday next month, the second Tuesday of the month, and it is Accessibility Room by Room, Discover the Keys to Unlocking the Barriers of Your Home. And that will be on Tuesday, June 13th. As always, you can register for the webinar and telelearning series free of charge on the Can Do MS website, mscando.org. For those of you participating live tonight, you will see a survey appear on your computer screen. Please take a moment to complete the survey and share your input. Your feedback does help us to continue to improve our webinar and telelearning series. You will also receive a PDF copy of tonight's slides by email. I do want to thank you and wish you a great evening. And if you would like to help support our webinars with a donation, you can text 970-626-6232. Again, thank you for participating and have a great evening.